Hello everyone. So my YouTube channel has a lot of videos on Chiari malformation and Syringomyelia that takes a deep dive into each of the subjects like clinical signs and MRI changes. This is, however, the one lecture, 1 hour, trying to bring it all together so that if you only wanted to watch one, this is the one to watch. Enjoy. So the learning objectives for this lecture is first of all to discuss the spectrum of canine Chiari and Syringomyelia, because this is really a very complex disorder. We're going to look at the clinical signs, how it's diagnosed, medical management, and going to discuss very briefly the surgical options. So, canine Chiari malformation is a reflection of human selection for brachycephalic features and a well-defined stop. It's a little bit more complex than that because not all dogs with brachycephaly have this condition, and it seems that certain breeds have disproportionately a large brain, and that miniaturizing their skull means that that brain becomes overcrowded. And in this video you can see at the side where it's labelled CMN or Chiari malformation normal, we have a normal Cavalier King Charles Spaniel without any evidence of Chiari malformation and Syringomyelia. Whereas on the right hand side we have a Cavalier that is affected with both Chiari malformation, pain and Syringomyelia. And you can see the video of the brains morphing between the two, starting with normal. And you can see that there is progressive shortening of the nasal tissue, pushing back of the brain. This is a dog with Chiari Pain, and then ultimately a dog with Chiari Pain and Syringomyelia. And I'd like you to observe how the whole conformation of the brain changes. And I imagine it as being like an accordion which is being squeezed together or expanded in the case of the normal dog. And I'd really like to get over that this is not just a cerebellar herniation, which is how it's described in many textbooks and in some other resources, but it's a whole brain and actual spinal cord problem where there is a disproportion between the size of the brain and the size of the skull in which it's contained. And so the normal Cavalier King Charles Spaniel, or at least one that doesn't have Chiari malformation and Syringomyelia, has a longer skull with a longer nose, but selection for these, one could argue, more adorable features with these so-called larger eyes, although they're not larger, they just have a greater palpebral opening so that you can see more of the eye, and clustering of their facial features to within in a smaller area in the face, which gives them a more baby-like expression with a shorter muzzle, that this is increasing susceptibility for Syringomyelia. What is Syringomyelia? Well, Syringomyelia is where the fluid around the spinal cord and within the ventricular system, which we call the cerebral spinal fluid, when that fluid is forced into the spinal cord substance itself. And by being forced into the spinal cord substance, it causes damage. And how does this occur? Well, there's many different theories, but the most popular theory is that because the CSF fluid is being obstructed, it is no longer hitting the subarachnoid space at the same time as the pulse pressure. So in a normal situation you'd have a pulsing blood vessel, and at the same time the CSF pressure would pulse at the same time, so both of these would be at high pressure at the same time. But when there is obstruction of this fluid, because the fluid cannot pass through the spinal arachnoid space as easily because of the overcrowding of the brain and the spinal cord in that space, that this gets obstructed, and this is at relatively low pressure when this is at high pressure, and vice versa. When this is at low pressure, this becomes higher pressure, and it allows fluid to be forced into the spinal cord substance. There are many arguments against that theory, but that is the most accepted theory. What breeds are affected by Chiari malformation and Syringomyelia? Well, the most common ones are the ones listed at the top. Chiari malformation is ubiquitous, meaning it's there all in every single dog, pretty much for the Cavalier King Charles Spaniel, unless they look like the dog that I showed you, and also in Cavalier crosses, especially if the cross is with a smaller dog. So for example, you can have healthy Cavapoos, but if the Cavalier sire or dam was bigger than the poodle sire or dam that it was mated with, then you increase the risk of Chiari malformation and Syringomyelia greatly. We also see it in King Charles Spaniels, Griffon Bruxellois, Affenpinchers, Maltese, Yorkshire Terriers. Again, in the UK, the Yorkshire Terrier can range from a very miniature dog to quite a big dog. These are the teacup dogs. It's very much associated with miniaturization. And likewise in the Chihuahua, in the UK, these are pretty much all apple-headed Chihuahuas, but if the deer-headed Chihuahuas still exist, they are much less at risk. So the very traditional shapes of dogs' heads are less at risk than the dogs that are now being selected for. And the Pomeranian, this is also the case, the very miniature Pomeranians, whereas they used to be much bigger dogs. We don't see it as much in the French Bulldog, Pug, Papillon and Boston Terrier, but it can occur. And in some brachycephalic toy breeds, it's pretty unlikely. For example, the Japanese Chin Shih Tzu and Lhasa Apso. My personal explanation for this is one, that these dogs have a different genetic origin, but also when you look at their skull and brain, they have a smaller brain. So when we're dealing with Chiari malformation and Syringomyelia, it's really a spectrum. And that has to be got across, because if you MRI scan many of these dogs, you may see disease, but they're not necessarily clinically affected. So these are clinically silent or asymptomatic, if we can use that term, though obviously dogs don't have symptoms. So we label them like this: Chiari malformation normal, Chiari malformation pain, Syringomyelia mild, and Syringomyelia severe. And Chiari malformation normal is that the dog is clinically normal, has no behavioural signs of pain, and you don't find any behavioural signs of pain on clinical examination, but when you do an MRI scan, you find a usually mild Chiari malformation. Chiari malformation pain is associated with clinical signs of pain, and the MRI appearance again has Chiari malformation, and they may or may not have Syringomyelia. So that's an important point to get across. Chiari malformation, the overcrowding of the brain in the skull, is associated with pain itself. They don't have to have Syringomyelia to have pain. Syringomyelia mild is when the MRI scan shows mild Syringomyelia, but there are no specific clinical signs of Syringomyelia. And in this instance, the syrinx is symmetrical, central, and has a narrow diameter. For the Cavaliers, that would be less than 4 millimeters in transverse diameter. It's not been quantified in other breeds. Again, the dogs may have pain associated with the Chiari malformation, but no specific signs of Syringomyelia. Whereas Syringomyelia S is having specific signs of Syringomyelia that relate to spinal cord damage. So these signs may be phantom scratching, scoliosis, weakness or ataxia. Now don't worry too much about the clinical signs at the moment, because we are going to go back over that. And the localization of that syrinx will correspond to those neurological signs, and it'll be a wide syrinx, typically more than 4 millimeters. And again, the dog usually has Chiari pain. Now, what are those clinical signs? So, Chiari pain. These dogs have signs of pain, and the most common one that you will see is postural, a so-called Valsalva mimic pain. So this is signs of pain when the dog is lifted suddenly. So the classic would be the veterinary surgeon lifting the dog onto the table, and the dog will give out a slight "eep" or a little groan as you lift them, and the owner may also notice this. The dogs may also yelp when they're jumping or when they're rising rapidly, and this is because the overcrowding of the brain and the spinal cord in the bony containers means that the fluid around the spinal cord, the cerebrospinal fluid, and the fluid within the brain in the ventricular system cannot redistribute quickly enough. And if you think about that, that's quite important, because the brain and the spinal cord sits in a sac called the meninges, and this allows the brain to be supported. But when you rapidly change position, stand upright, then of course this is under the effects of gravity, and the fluid has to redistribute to help support the brain. And if this can't happen rapidly, then you may get an excess fluid in the head, which gives you, humans describe, a bounding, very acute, severe pain. These dogs have facial head pain, and so they may have facial grimacing, as this dog has, and they may also rub at their face or scratch at their face. A scratching in this type of Chiari pain is very much directed to the back of the head and the face, so they will rub on surfaces or scratch at that area. You may find spinal pain, and this can be at any level, which may be a surprise because this is not associated with Syringomyelia. You may find cervical pain, thoracolumbar pain or lumbosacral, but cervical pain is more common. Lumbosacral pain less common. They have hypersensitivity to touch. They may not like grooming, and they won't particularly don't like their head being touched. They may not like their ears being groomed, and this may be something that's reported as by the owner. For example, this little girl here, you can see, this was a video still, but you can see how apprehensive she is about a hand coming towards her. She'd retired to her bed, she wanted to be left alone, and actually she was presented with a behaviourist for aggression, but this was actually repulsive behaviour to try and tell the owner not to pat her on the head. They may have an activity change, so be less inclined for exercising. This actually just shows an adaptation that one owner made. She converted a child's pushchair into a little buggy for her dog. In particular, this buggy was something that the dog could get in and out of according to her own wishes, and the owner sort of pushed this around, and then when the dog wanted to rest, she would come up on here, and when she wanted to exercise, she would off she would go. And this again is because when the heart rate increases, this increases the systolic pressure in the head, and the brain is unable to cope with that because the CSF pressure is unable to reduce quickly enough, and these dogs get an activity-induced headache. At least that's what happens when humans will describe this activity-induced headache, humans with Chiari malformation, that is. Sleep disruption is reported in many instances. They may wake up with a headache if we speak to, again, human sufferers with this condition. And so you may hear spontaneous vocalization at night. And likewise, the dogs may sleep with an elevated head, like this dog is doing. You would think this position would be very uncomfortable rather, but this is allowing fluid to drain down. And they may have a change in behaviour to other pets or people. This was a dog that was affected by Chiari Pain. You can again see how apprehensive he is, and the owner's foot here as this caregiver was trying to get this dog to back away into another room, but the dog was being very showing signs of aggression towards the caregiver, again not because the dog was aggressive, but because of related to pain. And they may also, because of the compression on the cerebellum, have a subtle forelimb hypermetria. So you can see this increased joint flexion here, an increased tone in this dog because of damage to that information going to the cerebellum. Some of the dogs may have these signs exacerbated with weather conditions, and this is one Cavalier King Charles Spaniel just before a thunderstorm. And we're going to talk later about how you have to give top-up medication. When the air pressure suddenly changes, especially when it suddenly lowers, they may get an exacerbation of signs. And I just want to show you this picture here, that the distribution of head and neck pain corresponds often to the sensory fields, receptive areas of the C2 nerve root. So the pain distribution is kind of upper neck, lower neck, and round the edges of the ears. They can also have pain in a trigeminal distribution, as is indicated by that pink flake, so over the face. And occasionally it will go down, especially if there is syringomyelia, down into the C3 nerve root distribution. So very much just kind of what we would call an occipital nerve distribution here, because the C2 nerve forms the occipital nerve. This is just a clarification of the rest of the area. You may think, what about there? That's the facial nerve. We don't tend to see that involved. Now, diagnosis of Chiari malformation and syringomyelia is challenging, not least because it requires an MRI scan, but the MRI, as I've tried to infer before, can sometimes not always be helpful, because we can have dogs with MRI signs of disease, so syringomyelia and Chiari malformation, but not necessarily have signs of pain. And so there is a questionnaire checklist, which unfortunately is only in one language and in English, and this is called Chiari Check. But any owner or caregiver or any vet can register and ask the series of questions. This is the location of it. And I have to say it's sponsored by a number of people, including the Hannah Hastie Memorial Fund and the Short Gang. So you can run through these series of questions, and it will give you a score as to whether Chiari malformation associated pain or syringomyelia is likely. So syringomyelia, as I've said before, is where fluid is forced into the spinal cord substance, and it has specific signs if it has damaged the spinal cord. So first off, because these dogs all have overcrowding of their brain and their into their skull, then they all have signs of Chiari malformation associated pain generally. But if the spinal cord has damaged the areas of the spinal cord associated with reflex scratching, then you may see this phantom scratching, which I'm going to show you a video of later. Phantom scratching is very different to the scratching that they get with Chiari Pain. They often don't make contact, and it has a rhythmic quality, and it's triggered. That's quite important. So it's triggered by walking, especially when they have a head collar rubbing on that area, or a leash rubbing on that area. And they do this kind of rhythmic action, which breeders will often refer to as doing the air guitar, because it's a kind of strumming action without actually making contact. And it's very disabling, because the dogs may not be able to walk on a leash without doing this kind of scratching. And it can also be triggered by excitement. They can have allodynia or paresthesia. I put the question mark in there because these are very subjective signs, which are described as having increased sensitivity to touch, which of course a dog can't describe, but you may get that impression because the dog may show some increased sensitivity. And often these signs are associated, the phantom scratching and the allodynia and paresthesia, with damage to the dorsal horn. So the dorsal horn is where the part of the spinal cord which takes in sensory information like touch and pain, and it's integrated through this area, then goes up to the higher processing centers. And you can see in this instance, so this is the grey matter here, and this is the spinal cord. We can see here that this is a great big ugly slash through the dorsal horn area, and it seems to be preferentially damaged in some dogs, especially in the Cavalier King Charles Spaniel. And so when this area is damaged, you get signs of neuropathic pain. So this is an example of a dog we thought had allodynia and because or paresthesia, because it was licking at this distribution here on its limbs. And here is another example in a dog. You can see the saliva staining here from where he's been licking. You can also appreciate this dog is quite weak by this kind of palmar-grade stance this dog has. The other thing that you get damage with when you have damage to this dorsal horn area is this sensory information here also includes proprioceptive information coming from the neck, and when that is damaged you can get an abnormal neck position and in particular cervical thoracic torticollis, so this twisting here, and when you look at the dog they often have a head tilt and the shoulders out to the side of the problem and the head tilts down away from the size of the dorsal horn damage. If you damage the muscle in that area, so down in these regions we have the ventral horn area, we have the neurons which are going to the muscle. When that is damaged you can get weakness, and because the syrinx is often in this cervical thoracic region, the weakness is often of the back and the thoracic limbs. It's not of the pelvic limbs, because the white matter tracts which are going down to the pelvic limbs, which you can see here, all of these little areas here, this is all the white matter tracts going down to the pelvic limbs, they are pretty preserved, and so the dogs will remain strong on their back, their pelvic limbs, but weak on their thoracic limbs. That weakness may result in tendency to scuff those limbs, and they can also scuff them because of proprioceptive deficits. Now I wanted to go back to the scratching here because this is very important, and it's something that people get very confused about, that there are two types of scratching in Syringomyelia. There's the scratching associated with head pain or rubbing associated with head pain, and the phantom scratching, which looks very different. So we can see that in this video here, we can see the dog rubbing her head associated with presumed head pain. And then we see the signs associated with phantom scratching, which you can see here is this strumming action, not making contact with the neck, induced by rubbing of the collar on the neck region. Will be one side only, and the important thing about that is that you should be able to trigger it by rubbing the affected dermatome, which is the area of skin that is associated with the dorsal horn damage. So it is very important to ask the questions, perhaps get video to be able to better categorize the scratching. Remember, dogs do scratch because of other problems. It's always embarrassing if you've diagnosed Syringomyelia in a dog which actually has fleas, and so these really need to be have the right questions asked to get the right answers. So diagnosis is made by MRI, and I'm going to take you through one particular image because the diagnosis made by MRI is not just seeing a cerebellar herniation, and that may be I'm afraid that some people, when they interpret this is all that they're looking at, whether or not there is a herniation and whether or not there is Syringomyelia, and there is more to it than that. So we're going to go through that step by step. So this is the cerebellar herniation, I should point out. This is the back of the skull, and this is the cerebellum that is popped out the back of the skull. This is the ligament that's between the back of the skull, the supraoccipital bone, and C1, and this is the spinal cord. So this is actually the dog that we saw the picture of, that was presented with this so-called aggression, growling and biting when the owner went to stroke her head. So the first thing that I look for is whether or not the brain is looking more like a soccer ball than a rugby ball. So the normal dog has a rugby ball shaped head, whereas the dog with pain has this more squashed shaped head looking more like a soccer ball. This is our girl here, and yes, she is got more of a football. I find sometimes it's helpful to actually put a little circle round there, yes, so she is brachycephalic. So brachycephaly means having a short skull brain case. It actually doesn't mean being flat-faced, and there's an often area of confusion in veterinary medicine regarding that. Brachycephaly is relating to this bit here. Many brachycephalic dogs are also flat-faced. Which is what we're going on to here. So this reduced craniofacial tissue. So the frontal sinus is often minuscule, and their forehead, the so-called forehead, because of course dogs don't have forehead, is actually the cranium. It's the skull and the brain, which is really quite horrifying. When you think about our forehead, it has those air-filled sinuses in front of our brain, but these dogs are literally going air, skin, bone, brain. And this is even worse in very thin-skulled dogs like the Chihuahuas, miniature Chihuahuas, and Yorkshire Terriers, Poms, that sort of thing. So our dog certainly is like that. A very pronounced stop, again with the junction between the nasal tissue and the frontal bone when we compare to normal here. And likewise, if we're selecting for away from this disorder, that's what we have to select for. There is no magic gene for this. It's a complex disorder, and it's likely that the inheritance of the large brain is dominant, and therefore the only way to get round it is to have a larger head. So the next thing that I look at is the craniocervical junction. So of course I will look at the cerebellar herniation. I'll look at whether or not there is kinking of the medulla. So in the normal dog, it should be pretty much a straight line. And in fact, if this was a German Shepherd, I would be able to put a straight line down here. It's a little bit of kinking in some miniaturized dogs, but you see here there's more extreme kinking. There is a greater, this little area here is to show you the increased tilting of the brain. There is reduced CSF signal in the foramen magnum. So if you look at the foramen magnum, then we may see reduced amount of fluid that is going through here. Actually, in this dog, it's much larger, which is probably why this particular dog here doesn't have syringomyelia. That will be the protective feature for this particular example here. But in this dog, we can see very much reduced CSF signal at this level, and certainly reduced signal in the cisterna magna. The occipital crest is reduced. This is quite a subjective thing. It's difficult to measure, especially as the occipital crest can be bigger in male dogs. This is a female dog, however, here. We can see how reduced it is there. And the supraoccipital bone, instead of being curved, it is much flatter or reduced. So the normal supraoccipital bone should come out way beyond the occipital crest. So in our girl, she has a moderate degree of kinking, it's not severe, certainly not as severe as some dogs, but it's certainly some overcrowding there. So then I look at the CSF spaces in these dogs because, as I've said before, there is too much brain in this skull. And the CSF spaces consist of the sulci. So here we have a normal dog, a miniature Schnauzer. So I'd like you to observe this normal dog, even in comparison to a normal Cavalier King Charles Spaniel. And you can see that although a miniature Schnauzer, if you think about it, it's about 8 kilograms, and a Cavalier is about 8 kilograms, you can see that the brains are very different. This so-called normal dog still has mild changes, which is why it's so difficult to interpret. So the miniature Schnauzer here has much bigger olfactory lobes. So this normal Cavalier has reduced olfactory lobes, whereas our girl has markedly reduced olfactory lobes, which are ventrally pushed down. The cerebellum still looks quite plump and tight in this compared to this dog. and there's just a general tightness available in this dog, whereas this dog looks like there is more fluid all around the brain. The fit is looser. We can see the subarachnoid space much more easily compared to this dog, and we can also see the sulci much more easily, but we can still see the sulci in these dogs. These are CSF filled troughs around in between the brain gyra, in between the brain folds, and we can definitely see them all in this dog, whereas this dog, especially rostrally, they're really quite reduced, not nearly as well defined. When we look at the cisterna magna, we can see the subarachnoid space passing around the spinal cord really quite clearly in this dog and in this dog. In fact, you could argue that's bigger than the miniature Schnauzer, but here you really lose that line of the subarachnoid space, and the cisterna magna, which is a reservoir of fluid, helps to function as a buffering zone. For helping to control those pressure changes, and that is severely reduced. And then we get dilation of the ventricular system, and importantly in this disease it's usually dilation of all four ventricles, so the lateral ventricle, the third ventricle, the mesencephalic aqueduct is often dilated, and the fourth ventricle is often dilated. The fourth ventricle should be a slit like that and like that, and that is because CSF outflow through the lateral apertures is being obstructed. So fluid can't get out, resulting in this backup of fluid through this system, and we can see the dilation of the lateral ventricles here, and actually you can see a fluid void going through the mesencephalic aqueduct area here because of the fast fluid flow. So then we get on to look at to make our overall assessment for this dog, and we can conclude, yes, this dog is at risk of Chiari pain. We would also back that up by doing the Chiari Check questionnaire, and that is now makes the diagnosis. We need to assess for syringomyelia, and you can see a very small central canal dilatation here. This dog doesn't really have syringomyelia, so I'm going to go on to some other images. The question is there syringomyelia? And also, where is it? In my opinion, it's not enough just to say it is present, but you should say how big it is and where it is. So to do this, in my mind, you should do sagittal imaging of the entire spine, even if you do some very quick images of the entire spine, for example, haste images, which can give you a very quick assessment. So we need to find out what is the cause of the syringomyelia, because syringomyelia will develop wherever there is CSF obstruction. For example, this is post-traumatic syringomyelia in a kitten, and there has been some trauma. There's been a fracture of this vertebrae here. You can see the healing is quite good, but the vertebrae is short in comparison to the other vertebrae. There's been bleeding into the subarachnoid space, which has resulted in adhesions, and then this kitten has developed a syringomyelia as a result of those adhesions. And this is one of the most important causes of syringomyelia in humans. Now, I just want to state here, this is severe spinal trauma. So little spinal cord trauma is not likely to result in a syringomyelia. There really has to be bleeding into the subarachnoid space. It's the adhesions that cause it. So our dog, this is her imaging, which she really just has this what we call a central canal dilatation. Now, how we interpret that does vary. A normal central canal is meant to be up to 1 millimeter in length, although a recent study by Mandiger's group found that most central canals were less than 0.5 millimeters. But a dilated central canal is definitely present if it's greater than 1 millimetre. And the official definition is when it's greater than 2 millimetres. The cutoff between dilated central canal and syringomyelia is a little bit arbitrary. There have been some studies that have said that you disrupt the ependyma, the lining of the central canal, once there is a dilation beyond 1 millimetre, and once the ependyma is disrupted, then you can no longer call it an intact central canal, and the definition of syringomyelia takes over. But for MRI purposes, then this is the accepted sort of standard. We also need to make sure that there isn't another cause of potential cause of pain when we're doing the imaging. Don't just make assumptions. And in this particular dog here, she actually had a slipped disc extrusion, and we can see this slight little bulge here, which you might not think is that exciting. You really need to do some transverse images, and you can see this. This is the normal here, and this is her area of syringomyelia, but we can see this little sort of doohickey here, and actually when a CT was done of this area, then we can really see that this is actually much more significant. And this was a Cavapoo that had a historic diagnosis of Chiari pain with mild syringomyelia. Then she had acute onset severe pain, and in this dog it was actually due to the disc. So don't just assume that it's due to the Chiari malformation and syringomyelia because it is a certain breed. Severe acute onset pain is more likely to be a more common cause such as intervertebral disc disease. So you also need to decide if the syringomyelia is clinically relevant. And as I've said before, clinically relevant syringomyelia is a wide syrinx. And so I will take transverse images through the syrinx at its widest point. And if I'm seeing clinical signs, then I would expect those signs to be corresponding to where there is a wide syrinx. So, for example, if a dog has weakness in the thoracic limbs, I would expect to see a wide syrinx in this area. If the dog had phantom scratching, then I would expect to see a wide syrinx in this area, which is the area which is involved with the scratching reflex. So then I look at whether or not it's damaging this dorsal horn, and in particular whether or not it's extended to the superficial dorsal horn, because this is very important for this phantom scratching and also the torticollis. And just to say that the shoulder is towards this side of the damage and the head is on the opposite side. As I've just said, the syrinxes that you get with phantom scratching are in the upper cervical region. And so we can have a syrinx which is similar size, but this syrinx here is completely clinically irrelevant. This dog had no clinical signs, whereas this dog had phantom scratching. And the way that I describe that is a bit like a donut. Of course, a donut is still a cake. It's still full of calories, it still fulfills all of its cake-like functions, and it's still doing everything it should do in cake-like terms. And if we have a hole in the middle of the spinal cord, then it is possible, I mean obviously there is some damage here, but it is possible for everything to be pushed to the outside rim and for the spinal cord to be still functioning, whereas this is a much more damaging syrinx. So you may get weakness of the back legs, but this is very, very mild. And if you're seeing a paralyzed dog, then this is not syringomyelia. Think of other causes like disc disease or degenerative myelopathy. And this particular dog, and the image that I've borrowed, is coming from a dog with degenerative myelopathy, which is associated with an SOD1 mutation, is an inherited disease tendency. So you these dogs do not end up being paralysed, and that's a very important take-home message, because that's something that is often miscommunicated to owners. The Syringomyelia and Chiari malformation, the main manifestation is associated with pain. Yes, some dogs do become weak if they have a very, very extensive Syringomyelia, as you can see here. So this little girl here had weakness and sensory deficits. You can see the knuckling over here, but this is more the exception. The other myth that I want to burst is that syrinxes remain very, very stable over time. So often when they have gone for diagnosis, this is because the syrinx has rapidly developed and the dog has rapidly developed clinical signs, which has prompted the referral for the MRI scan. And often if you repeat the imaging, you'll find that the syrinx is, in these clinically affected dogs, the syrinx remains remarkably stable over time. Syrinxes don't grow like this. They don't expand gradually over years and years and years. This is a misconception created by, it's difficult to know where it's come from. Sometimes from people who really are pro-surgery will say that syrinxes are going to gradually get worse, whereas there's no evidence for that. But it also comes from the Cavalier breeding community, and this is understandable, and this is because when breeders are screening dogs for having the tendency for syringomyelia, though not all dogs with that tendency will show signs when they're first screened. So as years go on, it is more likely that the dog will develop a syringomyelia, but these syringomyelias are not necessarily clinically relevant. The clinically relevant syrinxes tend to develop very rapidly and are apparent in the first 4 years of the dog's life. But a breeding dog may have a mild syringomyelia develop very gradually over years. This also may not change much over years, but we basically see about, in the Cavalier population, about 25% of the Cavalier population have MRI evidence of a syrinx at 1 year of age, and that rises to about 60% when the dogs are about 3 years of age. So I wanted to spend some time talking about treatment, as this is usually the area that people really want to discuss. And I've put in here the treatment algorithm, which is for 2024, that it hasn't needed to be updated for 2025. And this is available on my website, which is neurovet.co.uk. And the reason why there's lines over some of this is really just to indicate that each of these things has a separate YouTube video which you could watch at your leisure if you wanted to have more information about one particular aspect. So first of all, we're talking about Chiari malformation pain. And this assumes that a dog has already been given a licensed medication, but they've made a poor response to that. So first of all, diagnosis. Ideally, you would have an MRI confirmed dog. If that's not possible, then it would be lovely if you could use the Chiari Check, because that will give you a score. Otherwise, you'll have to make your assessment based on the clinical signs of Chiari Pain that I've listed earlier in this lecture. So does the dog have sleep disruption? Is the activity affected? Do they have postural pain, etc.? The first line treatment that we use is typically gabapentin, and this is because gabapentin reduces the excitatory neurotransmitter glutamate at the level of the dorsal horn. So it is useful for neuropathic pain, both associated with syringomyelia, which may be damaging that horn, but also Chiari pain, which is associated with central neuropathic pain as well. So we will often use this drug, gabapentin. If that is not effective, then our second line therapy may be to add gabapentin to a non-steroidal anti-inflammatory drug, or we may switch to pregabalin. Pregabalin is very similar to gabapentin. It also reduces the excitatory neurotransmitter of pain, glutamate, but pregabalin is more effective. It binds at the receptor for longer and has more bioactivity, so you can get away with a lower dose. And the doses for this you can find at my website and on the YouTube videos. The third line therapy would be to add a non-steroidal anti-inflammatory drug to this. And then fourth line, well, it really depends on the vet concerned, because often they will have a tried and tested regime. So for example, I will often use a combination of pregabalin and topiramate, but other people might prefer pregabalin and an NMDA receptor antagonist such as amantadine. Others may prefer pregabalin and amitriptyline. I've put a question mark there for CBD oil. Yes, CBD oil can be effective for pain, but you really have to have such a high dose that you will need to monitor liver function for that. As I've said before, you will often need to top up therapy on bad pain days. So these dogs can have an exacerbation of pain. So the first line therapy would be to add a non-steroidal anti-inflammatory drugs, but they may already be receiving that. The second line therapy would be to add paracetamol, and this is called acetaminophen. I may have pronounced that wrong. It's not a word I often say in some countries. In Britain, it's paracetamol. So this is very much top-up therapy. It should be said that in the UK, paracetamol has to be given under the direction of a vet. You have to prescribe it. And my third line is perhaps a little bit controversial. Again, there is supporting YouTube videos of this. I will give ketamine by subcutaneous injection, which is one-off or monthly. And for very severely affected dogs, I will actually give what I call a ketamine holiday, or I'll take them in for an intravenous infusion. The next thing, however, is phantom scratching, and that has a similar but slightly different approach. So these will have clinical signs of SMS, phantom scratching, and again, ideally we'll have an MRI score confirmation of that, but otherwise to use Chiari Check to have a high Syringomyelia score, or as a veterinary surgeon, if they've assessed it and found phantom scratching that can be triggered, then that is your diagnosis. So you do need to avoid triggers. I mean, that sounds like a very obvious thing, but in many instances it can't be avoided because the dogs haven't been taught to walk off a leash and have safe recall for whatever reason. Sometimes this is because they're rescue or many reasons. But if they can't be walked off a leash, then this compounds the problem. But if they can be walked off the leash, then please do so. So the other trigger to avoid is grooming, but I'm going to come down onto that. So because this is damage to the dorsal horn, and gabapentin reduces that excitatory neurotransmitter which has been disrupted by that damage to the dorsal horn, we start off with gabapentin and again shift to pregabalin as our second line therapy. Unfortunately, there's not an awful lot after that. Meropitant, which is a drug prescribed for vomiting under the trade name often at least in the UK, Cerenia, can help. But meropitant builds up it can't be given continuously, and also seems to stop working for continuous management. So we often try to use it on bad days, and especially during triggering events. So for example, if a dog gets very distressed with grooming, then you will give meropitant at a high dose just before that grooming. But also you have to manage their Chiari pain, because dogs with phantom scratching typically, 99 out of 100 cases, will also have severe Chiari pain. So everything in the previous slide also applies. Then we have weakness related to Syringomyelia. So this is less common, actually more common in certain breeds like the Chihuahua and the French Bulldog. So again, hopefully we'll have a diagnosis with an MRI confirmation, but that's just not possible in many instances. So the dogs may have a high Syringomyelia score from Chiari Check, but also your neurological examination here. Now, by far the most important treatment in this instance is physical therapy, physiotherapy and hydrotherapy. And I showed you the images of that very weak dog with the lordotic back. That dog went back to a straight back with hydrotherapy and physiotherapy and a lot of effort by the owner. And so these drugs don't help with weakness, don't help with damage to the and death of these nerve cells. Physiotherapy is by far the most important. We'll deal with surgery later. You may be wondering at this point about what about those drugs that reduce the CSF production? Well, the problem is they've not necessarily going to reduce that CSF production, but the next slide will deal with that, and then we have to reevaluate all those options. You may be wondering about corticosteroids. Well, at the current time, and I see hundreds and hundreds and hundreds of dogs with Chiari malformation and Syringomyelia. I only have 2 dogs that are receiving corticosteroids. In both of those dogs, the corticosteroids are not helping those dogs, and the caregiver's main challenge is trying to get those dogs off the corticosteroids. And in both instances, those dogs are having to use ketamine to help reduce the dog's pain to allow us to reduce the corticosteroids. Please do not blanket treat these dogs with corticosteroids. You are doing more harm than good. And I can't overstate that enough. These dogs do not die of this disease. So what you are doing if you overprescribe corticosteroids for this problem, especially in a young dog, is you are giving them another disease. You are giving them iatrogenic Cushing syndrome. Ultimately, that dog will become very weak because of the steroids. So yes, you can get an improvement, but that is not sustained, and eventually you will get problems. If I ever have to do it, it is only the very lowest dose to improve signs. And it really isn't necessary. As I say, I treat hundreds of dogs with this condition, and I haven't had to resort to steroids. The only dogs with steroids are ones that other people have prescribed, and inappropriately. So, what about the drugs that might affect CSF production? This might be dogs with hydrocephalus, and I don't mean ventricular dilatation, I mean clinical signs due to that ventricular dilatation. Dogs with very poorly controlled pain and weakness where there isn't a surgical option. And I'm putting here this little slide here which is showing CSF production. Again, there's a YouTube video supporting this. So based on available evidence, the first line of drugs that might affect CSF production is topiramate, and that is why it is my third line treatment way back here in this treatment algorithm. And that is because topiramate, as well as affecting neuropathic pain, also potentially affects it affects the enzyme here, carbonic anhydrase. The other drug which can affect carbonic anhydrase is acetazolamide, but acetazolamide has been shown not really to make much difference in hydrocephalus cases after 2 weeks, and has more adverse effects. Our second line of treatment might be omeprazole, but the problem with that is that you have to give an extremely high dose to have that kind of effect, and in fact there was an interesting paper published in Brazil which showed that, but that there have been subsequent papers that showed that this very high dose is associated with problems with the stomach lining. However, omeprazole might be a good option if the dog is also having brachycephalic related problems associated with regurgitation. So these are not first line drugs for me. I don't immediately reach for these drugs, and I definitely don't reach for cimetidine or furosemide. I never reached for furosemide. If I do want to give them, then these are the drugs that I might try. Again, if you're interested in that, I would compel you to look at the YouTube video on that. For cervical thoracic torticollis and scoliosis, well, actually, although it looks really, really severe, because it's a proprioceptive deficit, they actually seem to improve. They seem to compensate with time, and so this becomes less dramatic over time. So there isn't any specific treatment for this. This is not like the human condition. We have to put lots of rods down their whole spinal cord. So this will improve. So finally, I want to discuss about when surgery is indicated, and this shows one of the procedures, which here is you can see how the dog has to have its neck flexed and it's having a foramen magnum decompression. So surgery is indicated if they have severe Chiari malformation associated pain that is not improving with medical management, or signs that are suggesting progressive syringomyelia or hydrocephalus. And I have to bust a myth that truly successful syringomyelia surgery reverses the syrinx, reverses the filling mechanism, and the syrinx will collapse. And that a successful surgery is not stabilisation of the syrinx or a very small reduction in size, because that could happen anyway. Some of the syrinxes do get smaller with ageing in the dogs. So that can't be regarded as a complete surgical success, although some people may claim it, especially if the dog's have improvement in their clinical signs. And again, that is why the indication of the surgery is with severe Chiari pain, because you can have an improvement of clinical signs of pain. Also, if people are saying that they're getting good results with surgery, I would question that if they're not publishing their post-operative MRIs, because as I've said before, it will reverse the filling deficit. The other thing is that adhesions are caused by blood products. And so whether or not you have an implant in there or not doesn't mean that there isn't adhesions, because adhesions occur where there's blood, and unless you have a completely bloodless surgery, you'll still have adhesions. So as I've said before, surgery is, there is a supporting video on this which really helps explain the surgery in more details and has more pictures, but it's for Chiari malformation pain, or which is unresolved with medical treatment, or if there is progressive disease, or where there is weakness and you can give a good prognosis that by doing the surgery you'll improve that weakness, given that weakness is often due to permanent death of the cells. So what sort of surgical options are there? Well, first of all, you can put a syrinx into the ventricles if they're dilated and send that drain off to another space, such as the peritoneal space. You can widen the cranial spinal junction by removing the bone, and that's called a foramen magnum decompression. You can remove the adhesions, or you can put a shunt into the syrinx and put that drain into an alternative place, like the pleura, the peritoneal space, or the subarachnoid space. And finally, this is much rarer, you can cut the tethered spinal cord. So this would be cases of syringomyelia that are associated with a tethering of the spinal cord, such as spina bifida or myelocatasis. So I'd like to end at that point and say that there is an awful lot more supporting videos. I'm afraid they're all in English, but these are all of the videos that are on my YouTube channel that you may want to have a look at in greater detail. Thank you very much.